Welcome to this Step 2 clinical knowledge review on skin cancers and lesions test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for dermatologic malignancies and benign skin lesions, and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the dermatology and oncology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for skin cancers and lesions. Second, we will apply specific strategies for melanoma, basal cell carcinoma, squamous cell carcinoma, and actinic keratosis questions. And third, we will master the next best step question format for diagnosing and managing common skin cancers and benign lesions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the melanoma recognition framework. When you see a question describing a skin lesion, immediately apply the ABCDE criteria. A stands for asymmetry, B stands for border irregularity, C stands for color variation, meaning multiple shades of brown, black, red, or blue within the same lesion. D stands for diameter greater than 6 millimeters. And E stands for evolution, meaning the lesion has changed over time in size, shape, or color. If a question describes a pigmented lesion with any combination of these features, melanoma should be at the top of your differential. On the flip side, benign lesions tend to be symmetric, well-bordered, uniform in color, and stable over time. Seborrheic keratoses classically have a waxy, stuck-on appearance. Dermatofibromas dimple inward when you squeeze them laterally. Make this ABCDE framework your first mental step for every skin lesion question. Strategy 2 is the basal cell versus squamous cell split, and this distinction comes up constantly on the boards. For basal cell carcinoma, the classic description is a pearly, translucent, or flesh-colored papule with rolled borders and visible telangiectasias on the surface. It most commonly appears on sun-exposed areas, especially the face and nose. It is the most common skin cancer overall, but it almost never metastasizes. It is locally invasive, so treatment is important, but the prognosis is excellent. For squamous cell carcinoma, look for a firm, erythematous, scaly plaque or nodule, often with central ulceration or a non-healing wound. It typically arises on chronically sun-damaged skin and can develop from pre-existing actinic keratoses. The key difference is that squamous cell carcinoma can metastasize, especially in immunosuppressed patients. Whenever a question mentions a non-healing ulcerated nodule on sun-exposed skin with indurated borders, squamous cell carcinoma should be at the top of your list. Now let us go through high-yield stem recognition for skin cancers. For melanoma, the classic stem describes a changing pigmented lesion with irregular borders, multiple colors within the lesion, and recent growth or evolution. The key buzzwords are asymmetry, border irregularity, color variation, large diameter, and evolution over time. The initial step is always excisional biopsy with narrow margins, and Breslow depth is what determines staging and management. For basal cell carcinoma, the classic stem is a pearly papule with rolled borders and telangiectasias on the face of an older patient with significant sun exposure history. Biopsy confirms the diagnosis, and treatment is surgical excision or Mohs micrographic surgery for cosmetically sensitive or high-risk locations. For actinic keratosis, the classic stem is rough, sandpaper-like, scaly patches on sun-exposed areas. This is a pre-malignant condition that can progress to squamous cell carcinoma. Treatment options include cryotherapy, topical fluorouracil, or topical imiquimod. These stems repeat over and over on the boards. Let us work through our first practice question. A 52-year-old woman presents with a pigmented lesion on her left calf that has been growing over the past 6 months. On exam, the lesion is asymmetric with irregular borders, measures 15 millimeters in diameter, and has varying shades of brown, black, and blue. There is no ulceration or bleeding. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. This lesion is asymmetric, has irregular borders, shows multiple colors including brown, black, and blue, measures 15 millimeters, which is well above 6 millimeters, and has been growing over 6 months. That hits every letter of the ABCDE criteria for melanoma. Step 2. Apply the rule. The board rule you must memorize is, when melanoma is suspected, the initial diagnostic step is always excisional biopsy with narrow margins of 1 to 3 millimeters. You need the full lesion intact to accurately measure Breslow depth, which determines staging and further management. Step 3. Eliminate wrong answers. Reassurance is wrong because this lesion has multiple alarming features and cannot be observed. Shave biopsy is incorrect because it does not provide full thickness tissue, which means you cannot accurately measure Breslow depth. Wide local excision with sentinel lymph node biopsy is premature because you need a tissue diagnosis and Breslow depth before planning definitive surgery. The correct answer is C, excisional biopsy with narrow margins. Here is our second practice question. A 68-year-old man presents with a slowly growing papule on his nose that has been present for 8 months. On exam, the lesion is a pearly, flesh-colored nodule with visible telangiectasias on the surface and rolled borders. There is no pain or tenderness. What is the most likely diagnosis? Think through this one carefully. The key descriptors here are pearly, telangiectasias, and rolled borders. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes the textbook presentation of basal cell carcinoma. The key buzzwords are pearly papulae, telangiectasias on the surface, rolled borders, on the nose of an elderly man with likely years of sun exposure. Now let us go through why the other answers are wrong. Squamous cell carcinoma typically presents as a firm, scaly, erythematous plaque or ulcerated nodule, not a pearly translucent papule. Melanoma would show pigmentation changes, asymmetry, and irregular borders consistent with the A, B, C, D, E criteria. Seborrheic keratosis has a characteristic waxy, stuck-on appearance and typically occurs on the trunk, not with pearly translucency and telangiectasias. The correct answer is B, basal cell carcinoma. Remember, pearly plus telangiectasias plus rolled borders on the face equals basal cell carcinoma on the boards. Let us review actinic keratosis and pre-malignant lesions for the boards, because this comes up frequently. Actinic keratosis presents as rough, sandpaper-textured, scaly patches on chronically sun-exposed areas like the face, scalp, forearms, and dorsal hands. The key concept is that actinic keratosis is a pre-malignant lesion that can progress to squamous cell carcinoma. Treatment options include cryotherapy for isolated lesions, topical fluorouracil for field treatment of multiple lesions, and topical imiquimod as an alternative. Now here is why this matters on the exam. The boards love testing whether you know the progression from actinic keratosis to squamous cell carcinoma. They also test management decisions. If a question describes a non-healing or indurated lesion arising within an area of actinic keratosis, that should raise immediate concern for malignant transformation, and the next step is biopsy. Remember this progression. Sun damage leads to actinic keratosis, which can lead to squamous cell carcinoma. Here is our third practice question. A 70-year-old man with a history of extensive sun exposure presents with a rough, erythematous, scaly patch on his left forearm that has been present for several months. Recently, the center of the lesion has become thickened, firm, and ulcerated. What is the most appropriate next step in management? This is a classic question testing whether you recognize the signs of malignant transformation from a pre-existing actinic keratosis. Think about what the new thickening and ulceration tell you. We will walk through it next. Let us break down this answer. The classic pattern starts with a rough, scaly patch on sun-exposed skin in an elderly patient with extensive sun exposure history. That baseline description is actinic keratosis. But the question then tells you the center of the lesion has become thickened, firm, and ulcerated. These new changes are red flags for malignant transformation from actinic keratosis to squamous cell carcinoma. Now the key distinction. Cryotherapy and topical fluorouracil are both appropriate treatments for uncomplicated actinic keratosis, but not when there are signs of possible malignant transformation. Reassurance is dangerous here because you could be missing an invasive squamous cell carcinoma. You need a tissue diagnosis before you can decide on treatment. The correct answer is C, punch biopsy of the thickened area. This is a classic board pattern. Whenever an actinic keratosis develops new thickening, induration, or ulceration, Biopsy is the next step. Here is a critical test-taking pearl about benign skin lesions on the boards. You absolutely must be able to recognize the classic descriptions of common benign lesions because the boards love using them as distractors in skin cancer questions. Seborrheic keratoses have a waxy, stuck-on appearance and are the most common benign skin tumor in older adults. They can look alarming and even mimic melanoma, but the stuck-on quality and horn cysts on dermoscopy are key distinguishing features. Dermatofibromas classically dimple inward when you compress them laterally, which is called the dimple sign. Cherry angiomas are bright red, dome-shaped papules that are completely benign and need no treatment. Epidermal inclusion cysts present as firm, mobile, subcutaneous nodules with a central punctum. The exam loves presenting a classic benign lesion and testing whether you will overtreat or order unnecessary biopsies. Conversely, they may describe a melanoma and offer a benign lesion as a distractor. Knowing these classic descriptions cold will save you valuable time on exam day. That wraps up our review of skin cancers and lesions test-taking strategies for Step 2 clinical knowledge. Remember to review the dermatology and oncology chapters in first aid and your question bank. Focus on the ABCDE criteria for melanoma, the classic presentations of Basal Cell Carcinoma and Squamous Cell Carcinoma, the progression from Actinic Keratosis to Squamous Cell Carcinoma, and the benign lesion descriptions we covered today. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.